Welcome to this presentation about OPT and how it is used as a process to help nurses make clinical decisions. My name is Loretta, and I will be guiding you through understanding the components of OPT and how to use those components to cluster assessment data, develop nursing diagnoses, develop client-centered outcomes, nursing interventions, and evaluation of your interventions and outcomes to determine if your client is moving toward wellness. What you see in front of you right now is a visual of how the OPT clinical reasoning process occurs. Please don't think that nurses always use a tool like this with prescribed boxes and all they do is assess and then fill in the boxes. That is not what happens. Instead, in future semesters, you may not even see this document. Your clinical instructors and your professors will be asking you instead to write out your client data and assessment information in narrative form or on a data collection sheet. And then on your own, you will develop nursing diagnoses, develop a plan of care or outcome states, and write down your nursing actions and the literature supporting those nursing actions. But the reason why this visual tool exists, this piece of this framework in front of you exists, is to begin to teach you how the nursing process and the OPT process works. Now, you've already heard me use some language such as nursing process, okay? You will also hear other professors use language such as plan of care, all right? So all three of these words, OPT, nursing process, and plan of care, they end up in the same product. In other words, they end up in developing nursing diagnoses and outcome statements derived from your patient assessment data to help you move the patient toward a better state of wellness. As long as we're talking about the nursing process and the plan of care, I need to help you develop some language that matches up with OPT language. For example, over here, the client in context, what that really means is assessment data. Okay, so it means your assessment data. What is your assessment data? It's your subjective data, whatever the client tells you, and it's also your objective data, whatever you as the nurse actually heard, smelt, felt, observed with your own eyes. All right, and also included in this assessment data is what we call frame information. And as we move forward in this presentation, we'll talk more about what other kind of client data goes into the frame. Just know that in the nursing process language, the word assessment matches up with the words client and context within the OPT framework. Another OPT word is present state issue. In the nursing process language, a present state issue is a nursing diagnosis. Okay, so just know that those two are synonymous. The nursing diagnosis means the same thing as present state issue. Next, we have the outcome state. That is an OPT word. In the nursing process language, this is called your plan. What is it that you plan in order to help the client reach an optimal state of wellness? So plan is synonymous with outcome state. In the OPT language, we use the word nursing action or nursing actions. In the nursing process language, this is synonymous with interventions. Intervention, okay? So intervention means nursing actions. And then in the OPT language, test and judgment go together. And again, later on in this presentation, I'll talk a whole lot more about what the test means. Linking test and judgment up with the nursing process language. In nursing process, you'll hear nurses talk about evaluation. So evaluation is synonymous with both judgment and test. Well, why do we have two sets of language here? The reason is because nursing process has been the more traditional and long-standing language that's been around in the profession of nursing. It wasn't until in the 90s when the OPT clinical reasoning process was introduced as a stronger method of getting students to look at client data, cluster that data into meaningful categories, and then use those meaningful categories to develop nursing diagnoses or present state issues. What I did for you was to gather some data from a case study that you may encounter in your fundamentals class or even in lab. And I took important data from that case study and put it into this tool that you see in front of you. Now you'll notice that there isn't a whole lot of data there, and that's because if you use a piece of paper with prescribed boxes, you can't enter all of the essential data. However, given only the space that I have available on this screen, I had to be very selective about the data that I chose and put in here. So again, moving forward into taking care of real patients in the clinical environment, you won't just be writing information on this piece of paper because there just won't be enough room. But for the purpose of understanding OPT, this will work for us today. All right, so let's move beyond that and start talking about how you take client data and then use this form or process to help make sense of the data. Some essential information that I put in the frame here just to help you understand this patient a little bit is that she's a 72-year-old female, Caucasian, married, has 3 children, and was admitted with confusion and dehydration. She also has a history of dementia. That frame information should tell you something about the patient and should start to give you a picture of who this person is. Also in the client and context section over here, right over here is where we're at, I entered some subjective data. Not enough, certainly, but I only put as much as I had room for. For example, I wrote, the client states, "I don't know what happened. My husband brought me. Ask him." So again, subjective data is assessment data, but it's something that the client tells you. And so you would enter in key pieces of subjective data. And then also I entered here some objective data. And you can see some vital signs that I put down and then also some physical assessment information that I put down. Remembering that objective data is anything that the nurse sees, hears, smells, touches, assesses themselves. So in the OPT clinical reasoning process, what you will do is take key pieces of information. Well, let's pick out some of those key pieces of information here, because what you need to do then is cluster that data and develop nursing diagnoses or present state issues. All right, well, we have a 72-year-old female, and we know that as people age, they can start to have other conditions arise, and for example, this lady has had dementia develop, okay? We also know that this person is married and they have 3 children. Well, why is that a key piece of information? Well, if you remember that the definition of client means individuals, families, communities, and populations, and you know that this person has confusion and dementia, then you're going to start expanding your definition of client with this situation. Your client will not only be your individual patient over here, but your client will also be the spouse and the 3 children, because you're going to need to be providing education to them. Another key piece of information is that this patient has dehydration. Another key piece of information is that they say, "I don't know what happened." That links up with confusion over here and dementia. Also, I'm a little bit concerned down here about this pulse, the blood pressure, the O2 sat. Why is this person needing supplemental oxygen to maintain an O2 sat of 95%? The respiratory rate is okay. However, she has dry mucous membranes, she has tenting of the skin, and she has concentrated urine. All of this data, when you cluster it together in combination with this admitting diagnosis of dehydration, you cluster all of that data together, and then what you want to do next is go dig into your nursing diagnosis manual and figure out what nursing diagnosis matches up best with this data that you have. So I went and looked in our nursing diagnosis manual, and I chose a couple of nursing diagnoses that would match up with this patient based on the data that I have from the client and context section. So first let's talk about what is a nursing diagnosis and how do you write them. Nursing diagnoses are provided in two categories. You can have actual problems, and actual problems or actual nursing diagnoses are written when there is evidence that an issue actually exists. So let's take a look at what evidence we have from our 72-year-old patient. Well, they have this history of dehydration. They have a high pulse rate, they have a low blood pressure. In order for us to really say that they have a low blood pressure, of course we'd have to know her baseline blood pressure, and for the sake of this presentation, I'm going to say that her baseline blood pressure is 130/82. So she does have some hypotension going on. She has dizziness upon arising. Wait, isn't that new information? Was that on the prior screen? If it wasn't on the prior screen and in the client and context information, then at this point you would go back and add it in. Okay, but we did say on the prior screen that she also has dry mucous membranes. So this patient has evidence that something is wrong. Okay, so then we go to our nursing diagnosis manual and we look for a nursing diagnosis that matches up with that evidence. I found one, and it was called fluid volume deficit. Okay, so this thing right here in red is called the label, the nursing diagnosis label. And that label should flow directly out of the approved list of nursing diagnoses. The NANDA organization has scientifically worked at developing nursing diagnoses that fit with certain patterns of patient wellness as well as illness. And so we can't just develop our own nursing diagnoses and write them down. There is an avenue and a place for doing that, and what you would need to do is suggest that nursing diagnosis to the NANDA organization along with contributing evidence, and they might consider that and develop a nursing diagnosis. But for now, sorry, let me back up. For now, what you want to do is take your assessment data and then search through the book for a nursing diagnosis that matches with that data, and then choose an appropriate label. So I chose fluid volume deficit. The next thing that needs to be in a nursing diagnosis is this little piece here. R/T stands for related to. There is a structure, an approved structure for writing nursing diagnoses. So you want to put down the label and then related to, and you can either write it out, related to, or you can abbreviate it, R/T. Related to what? Well, I decided that it was the dehydration that was causing her fluid volume deficit. So this thing that you put after the related to is whatever is causing the nursing diagnosis. So I chose dehydration there. The next piece, the next connecting piece that should be in your nursing diagnosis are the words as evidenced by, and you can also abbreviate that as AEB, but it stands for as evidenced by, okay? And then you write down the evidence. Remember, we said an actual nursing diagnosis, right up here, has to have evidence that an issue exists. So you'll just write down the evidence that supports your nursing diagnosis of fluid volume deficit. And the patient could have 20 pieces of evidence to support the fluid volume deficit, but it's okay in the nursing diagnosis to choose the top 3 or the top 5. Okay, you just prioritize your evidence and write down the top 3 or the top 5. That's an actual nursing diagnosis. Now let's move on down here to a potential nursing diagnosis. A potential nursing diagnosis is written when there is no evidence that an issue exists, but the client is at risk for a problem. And so we want to implement a plan of care for at-risk nursing diagnoses to prevent that thing from happening. I decided that because our patient is dizzy upon arising and because they have a low blood pressure for them, that would put them at risk for falls. So potential nursing diagnosis will start with the words risk for. So she's at risk for falls, and then here's our connecting word related to what? Well, she has dehydration, and that puts her at risk for falls. She has this low blood pressure, and that puts her at risk for falls. And she has dizziness upon arising, and that puts her at risk for falls. What I want you to notice here is that because there is no firm evidence that she has fallen, she hasn't fallen, right? So no actual fall exists. Because there is no evidence of falling, there is no as evidenced by statement in a risk for diagnosis. So what you will notice here is that an actual nursing problem is a three-part statement. One, you know what, I'm going to change the ink color here, so bear with me just a second. One, you have a label. Two, you have a related to statement. Three, you have an as evidenced by statement. Whereas a potential nursing diagnosis problem is a two-part statement. One, you have a label. Two, you have a related to statement. This slide is meant to show you how the frame data was combined with the client and context data, and then nursing diagnoses were developed based on that data, and then you write the nursing diagnoses down. So I think you're starting to get the picture that in the OPT process and the clinical reasoning process, well, according to this structure, you start to collect your client data, mull it around, and try to figure out what that data is telling you about the client in terms of nursing diagnoses. And again, remember that in matching this up with language from the nursing process, all of this information over here would be called assessment. And then this present state issue stuff here, this is called nursing diagnoses. Okay? So you start with assessment data and then move into nursing diagnoses. Now, one thing that you're noticing about this form is that it's using some language like keystone issue. We're not going to focus on that in this semester. You're going to focus on that more next semester. But here's what I want you to know now about keystone issues. Keystone issue is the top dog in terms of nursing diagnoses. In other words, it's the thing that if you fixed that, because you're working so hard and prioritizing on that nursing diagnosis, if you work toward resolving that nursing diagnosis, then other things will be resolved as well. So imagine this. If we were to fix her fluid volume deficit and resolve that, and take care and improve her pulse and improve her blood pressure and get rid of her tenting and cause normal skin turgor, and also while we're doing all that, we're resolving her dizziness, would that also then resolve her risk for falls? If she no longer had a fluid volume deficit, would her risk for falls also be resolved? Well, probably. So the keystone issue is it's prioritizing where should I focus the majority of my nursing actions to meet this patient's overall healthcare needs. The next step in the OPT process is to write client-centered outcomes that address the nursing diagnosis. Outcomes should be SMART. The S stands for specific. Specific to what? Well, specific to the nursing diagnosis. In our situation that we've been talking about, our client has fluid volume deficit, and so the outcome should address the fluid volume deficit. Now, the client also has some confusion. There are other nursing diagnoses related to altered states of mental status. So you would write different outcomes for different nursing diagnoses. So the outcome needs to be specific to the nursing diagnosis that you're writing it for. It also needs to specify what the client will be doing or what they will look like when they're getting better. Measurable means that you're going to write an objective statement, something that another nurse can understand what they should be measuring. And I'll write you an example on the next slide so that you get a picture of what that looks like. Action-oriented is a verb-related statement that describes what the client will do. Now let me give you some help here. The best two verb-related statements to use would be that the client will demonstrate. In other words, they're going to show you something. Or the client will verbalize. Sorry, you have to write it down here. I don't have enough room. Or the client will tell you something. If you start out your outcome statement by using the words client will demonstrate, then that means they're going to actually have to show you something or show any other nurse something, and you're going to have to actually watch them. Or if your client statement says client will, if the outcome statement says client will verbalize, then that means that they need to tell you something. Be very careful about this. I have had students in the past say that their client will demonstrate going to church once a week. If you say that the client is going to demonstrate going to church once a week, that implies that you as the nurse are going to have to watch them do that thing in order to determine if they're doing it or not. It would be better to say that the client will verbalize attending church once a week. This whole thing that I'm talking about right now, that they're going to demonstrate going to church or they're going to verbalize going to church, that kind of outcome would be specific to a spirituality nursing diagnosis. It wouldn't be specific to a diagnosis of fluid volume deficit. I'm just using that as an example of when I've seen students get in trouble with how they write their outcome statements. So action-oriented words are typically either demonstrate or verbalize, but make sure that your outcome is still specific to the nursing diagnosis that you're writing. Okay? The outcomes also need to be realistic. It has to be achievable. It has to be something that the client can actually do, and it has to be realistic in terms of it has to be something that the nurse can either watch the patient do or hear the patient repeat back something. And then the time reference provides a target time for when the next nurse, or if you're still the nurse, when you're going to evaluate if this outcome has been met, not met, whoops, I meant to say not met, or partially met. Okay? Sometimes your outcome will be totally met and then you can cross it off and it's not a problem anymore. Sometimes the patient will partially meet the outcome, and if they only partially meet it, then maybe we need to think about rewriting an outcome that's maybe more realistic or maybe more measurable, or maybe your client's condition has changed for some reason that we can't have any control over, and so we just need to rewrite the outcome based on how that patient is right now. And in other situations, the client outcome is not met at all. And that could be because we haven't understood, the whole client situation. Maybe, again, the client situation totally changed. Maybe there was an unexpected death. There are a variety of reasons for why it's not met. We want to pay attention to whether it's met, partially met, or not met, because if it's partially met, then okay, good, we are headed in the right direction, but maybe we needed to give them a little more time. If it's not met, it could be because this outcome isn't written in a way that addresses specific client needs. But through these descriptions, I'm trying to help you get at the components of an outcome, of a SMART outcome. So in front of you here is an example of an outcome that was written by one of my students in the past for the diagnosis, the nursing diagnosis of fluid volume deficit. Let's see if we can pick out the SMART components, okay? The diagnosis is fluid volume deficit. So is this nursing outcome that was written specific to fluid volume deficit? Well, what does it say? It says the client will demonstrate signs of normal fluid balance. Okay, so yeah, it is specific to the nursing diagnosis. I'll give it that. Is it measurable? Well, you're a nurse coming on to take care of this patient, and you see that there's been an outcome that says client will demonstrate signs of normal fluid balance. What are you going to measure? What are you going to measure? Well, I think that this student intended for us all to assume what would be the signs of normal fluid balance. I don't know, you tell me, what are the signs? I guess what I'm getting at here is that this is not measurable. There's not enough there for me to know what to measure. And oh, by the way, the word normal should not be used in nursing documentation. You tell me, what's a normal blood pressure? Isn't it situational or contextual? For example, my normal blood pressure is 90/58. That's normal for me. So don't be using the word normal either, because there are many variations of normal when you're taking care of humans. So I don't see a measure here at all. Is it action-oriented? Well, yeah. They want the client to demonstrate that their fluid balance is improving. This word demonstrate here implies that the nurse will observe for changes in fluid balance. The client is going to have to demonstrate improved pulse, blood pressure, decreased dizziness, and the ability to get up and move around without dizziness and fainting. So I'll give it that it's action-oriented. Is it realistic? Well, I don't know. I can't answer that because I don't know what I'm supposed to measure. What signs am I supposed to measure? So no, it's not realistic. Is it time referenced? Is there a time listed here for when I'm supposed to reevaluate the patient and determine if they're improving? And the answer is no. There is no time reference here. So you think about this for yourself. You're the nurse taking care of this client, and you see this outcome in the medical record. How will you know the client's getting better? I don't know, because the outcome doesn't say. When will you reassess the client and test if the outcome has been reached? Don't know, because again, that time reference is missing. What exactly will be measured to determine if the outcome has been reached? Again, we don't know, because the measure is not there. Clearly, this is an example of an outcome that is not SMART. And actually, it's only got the S and A components. In contrast with the prior outcome that was written, let's pick this one apart and critique it for all the SMART components. Okay. Specific. Client will exhibit signs of stable fluid balance as evidenced by moist mucous membranes, blood pressure within normal parameters, pulse between 60 to 100, urine output greater than 30 mils an hour, balanced intake and output within 8 hours of initiating IV fluid replacement. Okay, specific. All of that stuff that's written in there is definitely specific to fluid volume deficit. It doesn't deal with pain. It doesn't deal with confusion. It doesn't deal with spirituality. So yeah, this outcome is specific. Is it measurable? I'm the nurse coming in to evaluate this outcome, so what am I supposed to measure? Oh, I'm supposed to check for moist mucous membranes. I'm supposed to see if the blood pressure is within normal parameters for this patient. I'm supposed to make sure the pulse is between 60 and 100. I'm supposed to check urine output, look for balanced I&O. Boy, compared to the other one that said look for signs of normal fluid balance, this one gives me something to measure. This outcome is definitely measurable. Is it action-oriented? Typically, your faculty will look for words such as demonstrate or verbalize, but this student did a nice job and said client will exhibit signs of stable fluid balance. That word exhibit means that they're going to demonstrate through their changes in their vital signs and through their changes in their skin turgor and through their urine output that they have fluid balance, a normal fluid balance. So this word exhibit, I can count that as an action-oriented verb that tells me what the client will do. Is this realistic? Well, I have to look at two things here when I'm judging this to determine if it's realistic. Is it not only realistic in what I'm going to measure, but also is it realistic in terms of the time reference that was given here? So let's jump ahead to time reference. Is there a time reference? Does this outcome tell the next nurse who's coming on, going to take care of this patient, when they should evaluate this outcome to see if it's been met, partially met, or not met, okay? Or not met, okay? So within 8 hours of initiating IV fluid replacement, within 8 hours, I'm supposed to come and see if their blood pressure is better, their pulse is where it should be, their urine output is good, and they have balanced I&O. That is a strong time reference, and here's why. If you say for your time reference that the client will have, they'll be exhibiting signs of stable fluid balance during hospitalization, that's too wishy-washy. I don't know when I'm supposed to evaluate that, and oh, by the way, maybe that means I'm only supposed to evaluate that on the day of discharge. If you wait 3 days later on the day that they're supposed to be going home or the day they're supposed to be going to their rehab facility, that's too late. Anybody who has unstable fluid volume, you need to be implementing measures to fix that and evaluating those appropriately. And I think that waiting 8 hours from the time you initiate IV fluid replacement is a good time to be evaluating this outcome. So I'm going to give it a check for time reference, and I'm going to say it's realistic. In the OPT process, it should be apparent here now that the outcome statement comes from the nursing diagnosis. So you start with assessment, develop your nursing diagnosis, and then from the nursing diagnosis, write the outcome statement. What we haven't talked about yet is this thing called the test. Each outcome statement has its own test. So, if you had another nursing diagnosis over here, then you would write another outcome there, and then you would write another test that relates directly to that outcome. We could have written an outcome here for our nursing diagnosis of risk for falls, and then we would write a test statement for that outcome, okay? So the test statement links directly with the outcome, and the test statement says what the nurse will do to determine if the outcome has been met, partially met, or not met. For example, what I wrote here is that you would observe blood pressure, pulse, urine output, and mucous membranes. And this observation is appropriate for an outcome that says client will demonstrate or client will exhibit. If you ask the client or if the outcome statement says client will verbalize, then your test statement would say ask client or talk with client, okay? So this is just meant to show you that the outcome statement derives from the keystone issue. The keystone issue derives from the client story, and that the test statement is directly linked to the outcome statement. This slide is just meant to give you some more language or words to attach to the test statement. The test statement is written as what the nurse or you will do to determine if the outcome has been met, partially met, or not met. And here's some examples here. Assess vital signs, assess intake and output, review lab values, ask the client if they're dizzy, look at mucous membranes, or observe. Evaluation does need to be timely. You don't want to wait too long. What you want to do is have evaluation at appropriate times, because if your client is not meeting the outcome, then it probably means that you need to try something new or different and redirect the care. And ultimately, you will be asked to make a judgment, and you've heard me use this language already quite a bit. If the outcome is met, that means it's been achieved and you can resolve it. If it's partially met, well, why did we only meet it part way, and what else needs to be done? If it's not met at all, well, why is that happening? And maybe we chose the wrong nursing diagnosis. Maybe we need to go back and restart at assessment and figure out what needs to be done next. Following the outcome, you will then write nursing actions that specifically address the outcome and specifically address the nursing diagnosis. We've been talking quite a bit already about fluid volume deficit, and so here are some nursing actions that you could potentially write for your patient who has fluid volume issues. What you'll notice here is that the nursing actions start with the statement, nurse will. This is what the nursing actions are what the nurse will do to help the client reach the outcome. In the nursing process language, nursing actions will also be called interventions. Let me get this down here, interventions, okay? And as you see here, each of these statements start out with what the nurse will do. Nurse will ensure adequate hydration. Nurse will evaluate intake and output. You might assess vital signs and mucous membranes, identify and discuss causative factors. Moving forward into future semesters, and also in this semester, when you write nursing actions, you will want to cite the sources where you got these from. Nursing actions should be evidence-based. They shouldn't just be pulled out of the thin air. There's a lot of nursing research and literature that will help guide best nursing actions so that your client has a better chance of reaching optimal levels of wellness and achieving that outcome that you set. So in this semester and in future semesters, we'll be asking you to cite the sources where you learned about some evidence-based nursing actions. And at this point in this presentation, you can see how we have started out with assessment data, clustered that data into meaningful patterns, arrived at a nursing diagnosis, fluid volume deficit. From that nursing diagnosis, created an outcome that is SMART. And then from that outcome, developed nursing actions or nursing interventions that will help the client achieve the outcome. Again, things are moving in this pattern from the right side of the screen toward the left side of the screen. The reason why the author of the OPT process made it this way, well, one reason why they made it this way, was to challenge automatic thinking. In American society, we read things from left to right, but they're having you think backwards and trying to push you to think differently. So they're going to have you work from right to left. Again, you can see here where it's under the nursing actions over here. I just listed 3 nursing actions. You most likely will have way more than 3 nursing actions. So trying to fit everything into this template or form won't work in the future. But just one more time letting you know that we needed to create some type of form to help you see how the process flows and how you move from assessment to diagnosis to outcome to nursing actions. This is going to be our last slide in this presentation, and so the last thing I want to point out to you is that eventually, well, actually with this patient, we said that within 8 hours of starting IV therapy, we were going to observe blood pressure, pulse, urine output, and mucous membranes and see what kind of improvement there was. And so let's say that we did that. Let's say that we assess urine output every hour, and they are putting out more than 30 mils an hour now, particularly because we now have them on IV fluids at 100 mils an hour. We've been monitoring their vital signs, and within 8 hours of starting IV fluid therapy replacement, the blood pressure now is at least 120/78, which is way better than the 90/60 that we had earlier. And the pulse is now at about 90, which is better than the pulse of 104 that we had earlier. And let's say that we educate the client about hydration needs, and the client is exhibiting taking some oral fluids in addition to the IV fluids. And so 8 hours into it, has our client shown improved fluid balance, such as an appropriate blood pressure? I'm going to enlarge this here a bit. Let's see if I can. Nope, I can't. Okay, so let's say they now have improved blood pressure, their pulse is better, their urine output is good, but they still don't have moist mucous membranes. Let's say that, let me get a different color here. Still we're having a problem here with moist mucous membranes. So I would go on over here, and in the judgment area, we would say that it was partially met. I'm just writing it on the side here because I don't have room to fit it in the box. And then you would write a narrative note underneath of that. It was partially met. The blood pressure improved, the pulse improved, the urine output is where it should be, but yet their mucous membranes are still dry within 8 hours of starting IV therapy replacement. What that means then for you is that you need to adjust the plan of care and start over. So maybe our patient doesn't have a fluid volume deficit anymore. Maybe now their bigger issue is, I don't know, maybe now we have an issue with impaired skin integrity. Something like that. So in the big scheme of things, this OPT process is very iterative or very circular. You may move through it quickly with a client, or it may take a couple of days for fluid volume to become fixed. What I'm getting at here is that it isn't static. We may have partially met one present state issue, but maybe now we've identified a new present state issue. And so you would start over here again with assessment, write a new nursing diagnosis, write a new outcome, and then write some nursing interventions that are specific to impaired skin integrity. Thank you for your full attention while you were listening to this OPT clinical reasoning presentation. In class, you will be given a case study scenario, and you'll be working in groups, and you will review client data and create your own OPT from that client story. I wish you all the best. Sometimes you'll also hear your faculty talk about the client in context section using these words: cues in the client story. So, in other words, just to reiterate in a different fashion what I've already said, it's where you enter data from your client assessment. You're going to cluster those cues together into meaningful patterns. Oh, sorry, this is what happens when you're working in your office. Just a minute. Okay, now I'm back. It's where you'll cluster the meaningful data in your client story, write those things in there, And then refer back to the frame section of the OPT clinical reasoning tool and see how the frame could be influencing your subjective and objective data. Now, I want to point out to you that in future semesters in your clinical setting, you will not be using that piece of paper with defined boxes. Instead, it will be more broad or more narrative in scope. And also next semester, Lori Corpening and Chad O'Lynn and Janet Banks and those other professors who help you grow your nursing knowledge, they'll be having you create a web of client meanings. And so they get into that in greater depth next semester. For now, what I need for you to know is that you'll be looking at your client in context. You'll be taking frame data and you'll be taking your subjective and objective data and start making sense of it. What is that data telling you? That's what you need to do now.